What's up everyone? Welcome to our second module on sutures and suturing. In the last video we learned how to place a single simple interrupted suture using an instrument tie. And in this video we're going to learn some advanced tips and techniques. Now when you're closing a wound using multiple simple interrupted sutures, it's important to be familiar with some principles of spacing and direction. First of all, you want your needle entry and exit points to be about half a centimeter away from the wound edges. If you only grab a little bit of tissue with your needle on each side of the wound, you risk causing tissue ischemia and even tearing the tissue when you tighten down your knot. And if you're closing a wound with multiple simple interrupted sutures, you want there to be about half a centimeter of space in between each suture. Now, when you tighten down all of your knots, you want them to be on the same side of the wound so that the closure looks more cosmetically appealing. Now, the thread material can easily pass through the tissues, so you can always just rotate a knot to the other side of the wound so that they all appear on the same side of the wound. And finally, when you're closing a wound, you want to put down your simple interrupted sutures from top to bottom, meaning that you're suturing towards yourself. Now, in some cases, a wound is particularly large and you need to start in the middle, but in general, you want to start at the top of the wound and lay down simple interrupted sutures towards the bottom of the wound toward yourself. The next tip relates to the angle at which you approach tissues with your needle. When you're suturing, you want your needle to enter the skin at a 90-degree angle, and then you want to follow the curve of the needle as you're pushing it through the tissue so that it also exits at a 90-degree angle. This helps reduce the amount of tissue trauma you cause, as well as ensure that your bites are uniform, or that you're taking the same amount of tissue with each pass of your needle on each side of the wound. One of the ways to achieve these 90-degree angles is to hyperpronate your wrist in the hand that's holding the needle driver. This allows you to rotate the needle so that you can enter and exit tissues perpendicularly. Another more ergonomic way of achieving these 90-degree angles is to use the forceps in your non-dominant hand to evert the skin edges or move them away from the center of the wound, just like the video on the screen here will demonstrate. This allows you to see what you're doing as well as achieve these 90-degree entry and exit points. Over the next few slides, you're going to learn how to best pronate and supinate your wrist to ergonomically manipulate the needle with your needle driver. And like you can see on the video on the screen here, when you're advancing your needle through tissues, you're moving your wrist from the pronated to supinated position. And actually, the whole process of suturing involves a repetitive series of steps where you're moving your wrist from the pronated to supinated position. On the screen here you can see a video of what your hand looks like moving from the pronated to supinated positions. Now when you're actually holding a needle driver, this circular motion of your wrist enables you to follow the curve of the needle to advance it through tissues. But obviously your hand is limited by how much it could supinate, and you'll find that this can limit how much you can advance the needle through tissues. So if your hand gets stuck in the fully supinated position, you'll want to go back to the fully pronated position to reset your ability to advance the needle. For example, the two pictures on the screen here are trying to demonstrate what it would look like when you just finished advancing a needle through two skin edges to approximate a wound. Now at the end of the motion, your hand is going to be in the supinated position, and the next step is to remove the needle from the skin pad so that you can tie your knot and secure your suture. Now it's very tempting for you to just let go of the back of the needle and pick up the front end of the needle in the same supinated hand position. But you'll find that when you try to continue supinating your wrist to follow the curve of the needle and remove it from the skin pad, that your wrist gets stuck and you can no longer supinate. So it's actually better to pick up the front end of the needle with your hand in the pronated position and then move to the supinated position to remove the needle from the skin pad. When you put everything together, this is what the repetitive supination and suturing looks like. You first want to insert the needle with your hand pronated and then advance the needle through the tissue by supinating your hand. You then want to go on the other side of the wound and pick up the needle with your hand pronated and then supinate your hand in order to remove the needle from the tissue. In the last slide, you saw me use my needle driver to advance a needle through the skin on both sides of a wound in one fell swoop, and this is known as taking it in one pass. You can take it in one when the needle you're using is large enough to take both sides of a wound without reloading the needle on your needle driver and while still maintaining those important 90-degree exit and entry points with your needle. And you can always use your forceps to help you position the tissue so that you achieve these angles. Now, if your needle is too short or too small, then you'll skive the tissue on the side opposite your first needle bite if you try to take it in one. And you can see how that can happen on the screen here, leading to a poorly approximated wound with uneven edges. Now, you also want to avoid taking a stitch in one if there's a delicate structure underneath the wound that you're closing. For example, if you're closing the abdominal wall fascia, you don't want to accidentally damage the underlying intestines with your needle or thread when you're traveling across the wound blindly. So in these cases, you actually want to take the stitch in two passes, where you use your needle driver to advance the needle through one side of the wound, then pick up the needle and reload it on your needle driver so that you can advance the needle through the other side of the wound. That way you can always see where the tip of the needle is and avoid damaging some delicate structures. Now you just learned how to do a simple interrupted suture, where the thread goes through both the epidermis and dermis before you tie the knot so that it sits on top of the skin. And this is a closure pattern that you would use to close a laceration in the emergency room, for example, so that your patient comes back to clinic when their wound is healed so you can remove these sutures. But if we're closing a wound in the operating room under sterile conditions, then sometimes we don't want our patients to be able to feel or see their sutures, so we can actually hide them underneath the skin to provide a cosmetic closure using the deep dermal suture pattern. Now, the two biggest differences between the simple interrupted and deep dermal suture patterns is that in the deep dermal, the thread is bringing together the dermis, and at no point does the needle or thread go through the epidermis. And number two, in the deep dermal suture pattern, the knot is hidden deep in the tissue at the level of the dermis. Meanwhile, in the simple interrupted, the knot is sitting on top of the epidermis. In the simple interrupted suture pattern, you start on one side of the wound and advance your needle through the epidermis and dermis before you cross over to the other side of the wound and go through the dermis and then epidermis before tying your knot, which will sit on top of the epidermis. To put it simply, you go superficial to deep and then deep to superficial before tying your knot. On the other hand, in the deep dermal suture pattern, you start deep and advance your needle from the dermis to superficial right below the epidermis, but not through it. And then you cross over to the other side of the wound and insert your needle right below the epidermis and go from superficial to deep. When you do this, both sides of the thread will be coming out of the dermis, and then when you tie your knot, it'll lay deep in the dermis. Now, you want your knot to lay deep in the dermis, otherwise it could spit, which means it'll pop out of the wound and serve as a foreign body nidus for infection. Now again, with the deep dermal, when you're going from deep to superficial, you want to come out as superficial as you can without going through the epidermis. But a common error that novices make with the deep dermal is that they just barely go through the epidermis before ultimately coming out below it. And so that can create a little piece of visible thread that looks like a buttonhole, just like you see on the screen here. And this is known as buttonholing the skin, and it should be avoided because it doesn't look good and can also increase the risk of a wound infection. On the screen here is a video of how to place a deep dermal suture. So first you would start by reflecting the skin with your forceps and then advancing your needle from deep to superficial right below the epidermis. As you can see in this video, at no point does the needle actually go through the epidermis. You then reload your needle driver and go to the other side of the wound where you would reflect the tissue again with your forceps and then go from superficial to deep. Then ultimately you would tie the suture just like you would a simple interrupted suture by using an instrument tie pattern. When you're tying knots to secure a deep dermal suture, it's important to remember some chemistry in the form of cis-trans isomerism. And to jog your memory, a cis bond means that there are functional groups on the same side of a plane, which in this case are the thread ends labeled T. Meanwhile, a trans bond means that these functional groups are on opposing sides of this plane. In the image on the screen here, you can see a scenario where you place a deep dermal suture, but the thread's ends that are deep are in the trans position relative to the plane that is the thread coming across the wound. And so if you try to tie a knot with an instrument tie with the threads in the trans position, when you try to push the knot down so that it sits in the deep dermis, it'll get blocked from getting there by this thread coming across the wound. To fix the situation, you first need to grab the suture's tail with your needle driver and move it so that both ends of the thread are on the same side of the plane created by the thread coming across the wound. That way, when you tie your knot, it'll end up below that thread, deep in the dermis where it belongs. And that concludes our second module on sutures and suturing.